Really late, but I think they are still on the way, I suppose. Anyway, so we'll start with a word of prayer, and then I'll introduce the speaker, and then we'll listen to the talk, and then we'll have the moderator leading the question answer. Because we're a small group, perhaps it'll be encourage more interaction, I hope. So request Achan to start with a word of prayer.
നമുക്ക് എഴുന്നേറ്റ് നിൽക്കാം, പ്രാർത്ഥിക്കാം. പിതാവിനും പുത്രനും പരിശുദ്ധഹായിക്കും സ്തുതി ആദ്യം മുതലേക്കും തന്നെ. ആമേൻ. പരിശുദ്ധനായ ദൈവമേ, സ്വർഗസ്ഥ പിതാവേ, 2025 ഓഗസ്റ്റ് മാസത്തെ അവസാന വ്യാഴാഴ്ചയാണ് ഇന്ന്. ജനുവരി 1 മുതൽ ഓരോ വ്യാഴാഴ്ചയും ഞങ്ങളെ ഇവിടെ കൂട്ടിക്കൊണ്ടുവന്നു. പല അവിടുത്തെ ദാസന്മാരിൽ കൂടെ പുതിയ പുതിയ കാര്യങ്ങൾ ഗ്രഹിപ്പാൻ, കേൾക്കുവാൻ ഞങ്ങൾക്ക് വിലയേറിയ ഈ ക്വസ്റ്റ് എന്നതായിട്ടുള്ള ഈ പുതിയ കാര്യത്തിനായി നന്ദിയും സ്തോത്രം അർപ്പിക്കുന്നു. ഇന്ന് ഞങ്ങൾ കേൾക്കുവാൻ പോകുന്നത് ബഹുമാനപ്പെട്ട ഡോക്ടർ ജോബിയിൽ നിന്നാണ്. അവിടുത്തെ ദാസനെ ശക്തീകരിക്കണമേ. അത് കേൾക്കുന്നത് ഞങ്ങൾക്കൊക്കെ ഒരു അനുഗ്രഹമായി തീരുവാനും അത് മറ്റുള്ളവരിലേക്ക് പകരുവാനും, പ്രത്യേകിച്ച് ഈ ഇൻസ്റ്റിറ്റ്യൂഷന് മറ്റുള്ളവർക്ക്, അത് പ്രത്യേകിച്ച് പഠിക്കുന്ന കുഞ്ഞുങ്ങൾക്ക് ഒക്കെ ഒരു അനുഗ്രഹമാക്കി തീർക്കുവാൻ സഹായിക്കണം പ്രാർത്ഥിക്കുന്നു. ഇനിയുമുള്ള സമയം അവിടുത്തെ കരങ്ങളിലേക്ക് തരട്ടെ. അവിടുത്തെ പരിശുദ്ധാത്മാവ് ഡോക്ടറെ നിയന്ത്രിച്ചാട്ടെ, നയിച്ചാട്ടെ. പ്രാർത്ഥനയുടെ സ്തോത്രം യേശു ക്രിസ്തുവിൻ്റെ വിലയേറിയ നാമത്തിൽ തന്നെ. ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
Good morning, everyone. Once again, it's my privilege to introduce Dr. Joby Isho, who is our guest speaker for today. Dr. Joby is a consultant psychiatrist in Essex in the UK, and he's been working there for over 22 years. Dr. Joby did his training in India. Thereafter, after his undergraduation, worked in 2 mission hospitals, in Bethany Hospital in Anekati, which is a tribal area near Coimbatore, as well as he worked in the Christian Fellowship Hospital in Odinchhatram. And thereafter, he went to the UK, did his postgraduate training there, and after that has continued to serve as a consultant there. He's also a recipient of a national award by the Royal College of Psychiatrists. He's also a man who loves God and the things of God, and he's been very active in student work and ministries as well, alongside his professional work. So when I heard that I was in the UK last month, we connected again after many years, and I came to know he's coming on vacation, and I requested him to kindly give a talk on something, because having worked in the National Health Service in the UK for many years, I'm sure there are a lot of learnings we all can learn, as well as we can share and have some interaction. And that's the reason I asked Joby to talk on a topic, and so Suman and Abel, myself in our Quest core group have been brainstorming what is the best topic of general interest. And so this is what we arrived at, which we thought will be something perhaps useful. And I really request to some of the youngsters like Medha and all to ask good questions at the end of it. And also the nursing team is here as well. So over to Dr. Joby for the talk, and we hope that we listen to you. You want to use a hand mic, or you want to be stuck in one place? Which do you prefer?
Good morning, everyone. Thank you for inviting me to talk to you all. And also, I just want to thank you all for the fantastic work that you're all doing here. Most of us who have families here use this hospital for their medical needs, and the care, the compassionate care that we have seen and witnessed is truly marvelous. So thank you all for that. And thank you, Dr. Philip, for the kind introduction. Before I start, I thought I will do a bit of a confession. I think a lot of people like to hear confessions, isn't it? So let me start off with a personal story, my journey into psychiatry. So after finishing MBBS, or even when I was doing my MBBS degree, I always wanted to sort of, post-MBBS, I want to go and serve in hospitals which looks after people who are less fortunate than us. And that's what led me to 2 mission hospitals. So the first mission hospital was fantastic in the sense that that's where I gained all the skills. I worked in medicine, surgery, so gained some minor surgical skills also, and was very confident to manage any patients that come across my way. I was not much interested in pediatrics and ops and gynae, so it's not that I thought it was a bit too much for me, so I stuck with medicine mainly. And then I went to the mission hospital in Anekati, Bethany Medical Center. As a junior doctor there, you are on call 24/7. And for example, in the evenings we might play basketball or something like that, and then a patient comes and we have to rush to the small casualty, see the patient, and then go back and play whatever you're playing, either badminton or cricket or whatever. So there was a scenario when there were two specific patients. I had absolutely no clue what to do. And those days, even I had no idea what the diagnosis was. So that really thought me thinking. I mean, there was this young lady who had given birth to a child. And this lady was just walking around the bed. The child is on the bed. And I had absolutely no clue what's going on. Then there was another patient who came manic. He was just running amok. And I knew he probably has a manic or a bipolar affective disorder, but did not have any clue what to do. That is what sort of challenged me. Okay, I thought again. I was a confident doctor, and I realized I don't know everything that I need to know, and that what challenged me to take up psychiatry as my subject of choice, or specialize in psychiatry, and got into PG in India. But then at the same time, I was preparing for PLAB, and then I sort of ditched the idea of doing PG here and went to UK to do my postgraduate studies in psychiatry, and I haven't looked back. The reason, again, one of the reasons why I chose, we discussed and chose this topic is psychosis is something that we see everywhere. It's not an uncommon condition. We come across this from time to time, but we might not know what exactly is going on. And that's again in the, as medics, we also have the same issue, because when I studied MBBS about 30 years ago, psychiatry posting was just 2 weeks. And I had a dental posting for 2 weeks. So the dentistry posting and psychiatry posting was exactly the same. But I know that now things have changed over the last 10, 15 years. I think psychiatry in medical care, curriculum here, there's some marks involved in the exams, and so we are forced to study things about psychiatry. So, but those of us who are of the slightly older generation of medics, we have absolutely no clue what we should do when it comes to mental illness. Thinking about brain, it's one of the most complex organs in our body. It has 86 billion neurons, 100 trillion connections between these neurons. For a context, billion, billion is 9 zeros and trillion is 12 zeros. So the number of neurons, the number of connections, it's fascinating. We don't know everything about it, completely about it yet, but if something happens anywhere in these connections, things can misfire. And we all carry a smartphone these days. All of us have a smartphone. One of the examples that I use sometimes with patients, or even sometimes with other medical colleagues, is that our smartphones have it has a hardware and a software. Sometimes there can be issues with the hardware. It doesn't happen that often. There can be issues with the hardware, and sometimes there can be issues with the software. I sort of explain that mental health difficulties, we can compare that to issues with the software of a computer or a handheld device. Because if there are issues with the software, obviously you will need to send that person to a psychiatrist. If it's an issue with the hardware, probably you'll have to send that person to a neurologist. So to start off my presentation, I'm just going to give a case scenario. This is a 25-year-old lady of Indian origin who's single. She is a smart young lady. She's working in a law firm, training to be a lawyer. Law degrees are very, very challenging and difficult. It takes a long period of study, and then they have to have practical experience. It's almost like our medical training. So it's a very challenging sort of field to be in. everything was going on well, but then a few months prior, her friends and family noticed some changes in her behavior. So she started behaving slightly erratically. Her concentration in doing things were not too great. She was becoming quite irritable. These sort of behavioral sort of changes were noticed by her family. And she comes from a background where there's no family history of mental illness. She did not have any previous history of mental illness. There's no significant medical history. There's no history of any substance use or alcohol use. The only thing that was going on in her life at that time, she had just her slightly long-term relationship had just broken down. And as I mentioned, there was quite a lot of stress at work. She had to keep up with a lot of things. And then when she was brought into the accident emergency, and where she said she believes she had a miscarriage. She did not have it. I mean, she had her normal period just a week ago, and she thought it was a miscarriage. She was very thought disordered. Thought disordered means she was not talking sense. She was just jumping from one topic to another. And then she mentioned of hearing her boss talking about her, and a lot of people in that conversation talking about her, and a lot of negative things. And she had absolutely no insight into what was going on. So keep the scenario in your mind. I'm just putting the scenario so that as we go through the talk, some of the things that we discuss will resonate with what I've mentioned so far. So what is psychosis? Psychosis is mainly when a person's thoughts or emotions or feelings become so disturbed that everything, they lose touch with reality. Sometimes they experience very unpleasant, unusual, and frightening thoughts. They can become quite paranoid. It is a scary place to be. And one of the things about psychosis is that people who are close to them will notice something is going on. I mean, the person who is experiencing this would not realize anything at all, but people close to them will notice changes in their behavior. And this could be for a few months, or sometimes it might be longer, but people close to them will notice changes in their behavior. What are the core symptoms? So I'm not sure how many of you have heard these terms. I mean, these are sort of specific medical terms, but delusions. I mean, so delusions are basically, they think about things which are not real. It can be day-to-day mundane things. They attribute a special meaning to something that is happening. For example, I'm looking at the clock there. The clock sometime, at some stage is going to become 8:23. So someone with psychosis can think, okay, when it sort of turns to 8:23, that has a special meaning to them. Or sometimes, something, let's say a bug, a house fly or something, just comes into the house. A person with psychosis sometimes can think, oh, this housefly is spying on me. This thing which is right in front of me is spying on me. Or sometimes, with the digital age, you might see a message on your phone. Then they might think, okay, there is some special meaning to this particular message that has come by. It will be just a normal message by someone. So they become very paranoid. And there's an element of, they believe that they are being persecuted. So, and this is quite distressing to them. And their thinking process becomes very disordered. So what that means is that their thoughts will be all jumbled. Things don't make any sense at all. I mean, I have patients who sometimes write to me, and when they are well, whatever they write to me sounds very normal. When they are not well, when they write to me, I mean, usually there is one of the things. What should I say? A difficulty with the job as a psychiatrist is that not all patients will agree with what you're saying. Some patients, once they gain insight, they will agree with what you're saying. They will accept that they have a mental illness. But some patients might not agree. And then, when they write to you, they will be writing things which doesn't make any sense at all. I mean, the words doesn't match, and that again shows that disordered thinking pattern. Then the other common symptoms that they will experience is hallucinations. So hallucinations could be seeing or hearing or feeling things which are not real. To us, it might we might think, what are they talking about? They will say that I can hear someone talking about me. It will be as clear as I'm speaking to you. The conversations will be there. It's not inside the head, it's in the external space. As you are listening to whatever I'm saying, they will hear conversations happening. And then these conversations won't be just by one person. Sometimes they'll hear multiple people talking in their external space. And sometimes they will hear there won't be anyone there, but they will be hearing conversation of multiple people talking about them. And it is quite distressing. And sometimes, they think they are out to harm them, and a lot of negative stuff will be there. And sometimes, some hallucinations, some patients will say that they become part of their life, and they enjoy these hallucinatory experiences being there. That means they're hearing all these things around them. But the difference is that there's no one there. So sometimes, for example, a classic thing that I hear from patients is that I can hear my neighbor talking about me. It might be from, some of the houses in the UK, the walls are thin. It's not like a brick wall. It'll be plasterboard, but you still can't hear exactly what the other your neighbors are talking. But these people think I can hear through the wall what they're saying, and they're talking about me. So these are sort of auditory hallucinations, which we call them as auditory hallucinations. Sometimes they can see things. Sometimes they feel that their body, they can feel bodily sensations and things. Sometimes they feel that someone is touching them. So those sort of hallucinatory experiences can be there in some cases, some of these cases. But one crucial thing which comes before all this, or whilst this is happening in their life, is that we will notice some challenges in their normal day-to-day life. If they're in school, there might be some challenges in school. If they're in work, there might be some challenges in work. If they're married, in their home life, there can be some challenges which are not normal. These are sort of early warning signs. When someone develops a full-blown psychosis, when all the other symptoms are there, then when you think back, you'll say, oh yeah, these things have been happening for the last few months. Then of course there will be problems with their sleep. They won't eat well. They wouldn't be able to concentrate on tasks. These are some of the other symptoms that can happen whilst they are unwell. Another crucial bit of all this is thoughts of harming themselves or others. Because all these things are happening in their world or in their mind. Sometimes they take their own life to prevent, or because of the stress that's going on, they end up taking their own life. So they will have suicidal thoughts and they end up taking their life. People with schizophrenia, almost 10%, the risk of suicide is quite high. Almost 10% of people commit suicide. And then there is also the risk of them harming others. Even though it's rare, but that is a real risk. Because again, the reason why they do it is because of all the delusions, all the unnatural thinking that they are having. They might think, oh, this person is trying to do something against me, and then they become very paranoid, and they might end up harming others. So these are some of the symptoms that a person with psychosis will face. What are the common conditions? So I'm concentrating on first episode of psychosis. That is what I'm sort of concentrating, so that those of us who are confident or who see people with mental illness, we will know how to pick up psychosis. But my aim is so that the subtle symptoms that we see in our day-to-day clinical practice, we will be able to pick them up. Initially, when someone comes with a first episode of psychosis, we don't put a specific diagnosis, but over a course of a period of time, these are the common diagnoses that will be there. As you can see on the screen, schizophrenia is predominantly delusions, hallucinations, disorders in their thoughts. Schizoaffective disorder is very similar to schizophrenia, but then there is a mood component also along with the schizophrenic symptoms, which happen simultaneously. They can be manic, they can be depressed. Delusional disorder is something where hallucinations are not that prominent. It's more of the delusional symptoms are prominent. Delusional disorder is slightly difficult to treat when compared to the others. Then there's something called as acute and transient psychotic disorder. This is where usually it is very brief. It can, it is usually stress-induced. They can become psychotic. You treat them, they become well within a few days to a few weeks' time. I have a few patients with that condition. Then, of course, there's the bipolar affective disorder. Bipolar affective disorder, not all of them become psychotic, but there are some who become psychotic. Bipolar affective disorder is where there are two spectrums in their mood. Their mood can become low, that means depressive phases, and then their mood can become high, and they become manic. So they will do things which normally they will not do. And the thing about this condition is that once they become normal, they feel so embarrassed about what all the things that they did when they are in that sort of high phase. I mean, there are times patients do all sort of stuff. I mean, they might, when they are manic, they can do stuff like jumping around in the house, doing really, for example, sometimes they break things, throw things, So the spectrum changes from depressive phase and high phase. Then there is depression. When depression becomes very severe, they can also present with psychotic features. So when someone is really depressed, they are not eating or drinking, not doing, and they can also present with psychotic features, mainly sort of negative features, like they will think that their organs are rotting and they are going to die. Those sort of feelings will be there. Postpartum psychosis, I'm sure a lot of people will be aware of postpartum psychosis. That's, again, a condition that we have to be mindful of, particularly post-delivery, a couple of weeks post-delivery. They develop symptoms where they don't bond with the child. What generally happens is they think something bad is going to happen to the child. There have been a few cases in the UK where the mothers have killed their baby due to postpartum psychosis. I mean, postpartum psychosis is a very dangerous condition. It has to be treated promptly, and it has to be recognized and treated promptly. There are sort of mechanisms in the UK to, after a lady has delivered a child, they are monitored by the midwife. They have health visitors going them. They do screening questionnaires on depression, looking for postnatal depression, postpartum psychosis. The next question: how common is psychosis? Do we really need to be that worried about psychosis? I was just going through data about other medical conditions, not psychosis per se. What I found is that prevalence of a lot of other conditions, like, for example, cardiac conditions, for example, is different in the UK population from here. I mean, here, what I believe is that you see more cardiac events in, we are seeing more and more cardiac events in younger age group people, whereas in the UK, we see cardiac events happening more in the people who are slightly on the older age group. But interesting thing about schizophrenia or psychosis is that the prevalence of in the UK and India is almost the same. I mean, if you look at, in the UK it's 0.3 to 0.7%, whereas here it's 0.23. I have a feeling the Indian data probably will be slightly underestimated because of difficulty in collecting data, and a lot of the cases probably are not undetected. But the prevalence is more or less the same across the world. In the UK, it's more towards the 0.7 sort of mark. And the broader clinical psychosis, that's all the other conditions that I mentioned, it roughly is 1.45%. So that is quite a big number. So when we look at Anecdotally, when I sort of, when we are part of certain groups, we know how many people in your group have a mental illness or something like that, and it equates to around 1%. Not exactly 1%, but it equates to around 1%. That's one in 100. So it is quite a big number. One question that a lot of people ask me, particularly patients, they ask, one of the questions, what causes psychosis? Is it something that I have done, as parents I've done, or is it something something I didn't do? Like any illness, whether it's a medical illness or a mental illness, the causes are very similar because it's an interaction of multiple factors coming together and causing an illness. So it could be it could be biological causes. When I say biological causes, it means some of it could be inherited from family, but not, most of the patients whom I see, there's no history of mental illness in their family. There is a level of heritability. I mean, about 10 to 15% is there. For example, the general population risk is 1%, whereas if there's a family member, that means a direct family member having mental illness, the risk is more. It's about 10 to 15%. Then there could be psychological factors, stress, trauma, childhood adversities. There is a risk of psychosis probably in migrants, particularly in the Western world. Again, it's to do with they going through a lot of stress and factors like that. Then there are other factors like use of drug and alcohol, stuff like cannabis, cocaine, things like that can trigger. And of course, there are some medications which can trigger psychotic episodes. But the bottom line is that it's an interaction of multiple factors together. It's not a single factor that causes psychosis. Probably you might ask the question, can physical illness display psychosis? Yes, I mean it can. It is the straightforward answer, but it is very rare. When you look at all the number of psychotic patients, the risk of physical illnesses causing psychosis is pretty small. Almost 95% of the psychosis presentations are due to a mental illness. There will be about 5 to 10% which can be due to a physical cause. And one of the most common psychiatric presentation in a hospital setting, in a general hospital setting, probably will be delirium, which is the acute confusional state. In the UK, in one of the hospitals, the South London and SLAM, which is South London and Maudsley NHS Foundation Trust, which is equivalent to our NIMHANS here, they had done a study, and I mean they went through records of a huge number of patients, and they found that about 3% of those who admitted there had a medical or an organic cause for the psychotic symptoms. Next few slides, I'm going to list, though they are busy slides, but I'm going to list what are the medical conditions that can cause or that can present with psychotic symptoms. I'm not going to go into detail, but just for your information, I'm just going to list all of them. There are various neurological conditions that can present with psychosis. The commonest probably, there are TLE, temporal lobe epilepsy, can present Parkinson's disease, stroke, tumors, and then there are various autoimmune inflammatory conditions. The anti-NMDA encephalitis. I mean, these are currently, there's a lot of research going on. The first two on the autoimmune you have to treat those, and the psychotic symptoms will subside, and then the other few conditions. Then there are various endocrine metabolic conditions which again can present with psychotic symptoms. Problems with the thyroid, some vitamin deficiencies, hypoglycemia or hyperglycemia. I've had patients with hyperglycemia presenting with psychotic symptoms. And then obviously infectious diseases, HIV, encephalitis, CJD. I mean, these are some of the infectious diseases that can present with psychotic symptoms. I'm not sure. how much of substance use is there. I think I've read in the news, Kerala is sort of going up on substance use. So cannabis, cocaine, amphetamines. I mean, I have a lot of patients who use all of them. It causes psychosis. And then, of course, some of the medications that we use, steroids. I mean, we all would have seen episodes where patients with steroids causing psychotic symptoms. Alcohol withdrawal, I mean, delirium tremens, I think most of us will be aware. This is a scenario which happens generally in medical wards. I mean, I've come across these sort of scenarios where we are called for psychiatric consultation, where you go to the ward, medical ward, you will see this patient under the bed because he's scared that there are rats and things all running around the room. And when you take a history, he was drinking alcohol heavily, and post-surgery, he hasn't had alcohol for the last few days, and then he has a delirium tremens. So alcohol withdrawal is something that can be seen. I don't know how prevalent alcohol use is here, but we see delirium tremens there. One of the key thing in detecting, figuring out whether it's a medical cause or psychiatric cause, the setting is very important. So when I mean the setting, I mean if it's a hospital setting, we know why this patient has got admitted to the hospital. So if they've got admission to the hospital for a medical condition and then they're presenting with psychosis, then the safest thing or the best thing to do will be to treat the medical condition. They might need some form of antipsychotics to help at that stage, but setting is a very important discriminator to figure out whether it's a medical cause or a psychiatric cause. And then as we all know, the symptoms will be very acute or fluctuating onset. When I meant the age of onset, so usually we see these sort of conditions in a slightly older age group if it's due to a medical reason. Psychosis, first episode of psychosis, usually in the younger age group, in their 20s or even before 20s. There are times when psychosis can develop at a later age group, but that's not as common as the first episode of psychosis in the younger age group. The first episode of psychosis in the UK, the age bracket is from 16 to 65. So anyone presenting with psychosis at that stage, first episode, they will be looked after by the first episode of psychosis services. The other thing is that there will be other clinical signs, like their orientation and things like that. They will be quite confused, disoriented, which is not the case with a psychotic patient due to a psychotic illness. And also, I should add that the response to antipsychotics will not be as straightforward as someone with a psychotic illness. So the question is, does early intervention really matter? I mean, if we look at a condition like cancer, we know that we have to pick up the diagnosis quickly and treat them quickly. I'm just going to compare the UK cancer targets. So NHS is a huge organization, government sector organization. I mean, in the UK, 80% of the patients are treated through the NHS, which is the government hospital setting. It's only 20% of the patients are treated through the private sector. So obviously, because it's a huge structure, a huge organization funded by government or our taxpayers' money, things have to be rationalized in a way which meets all sort of parameters. So the target for cancer in the UK, so the target is that, so every condition will have a specific target. So cancer, the target of diagnosis is 30 days and target of treatment is about 62 days. So if someone is diagnosed with cancer, then they have to start treatment within 62 days. Can you guess what the target for psychosis is? Anyone would want to guess, take a guess what the target for psychosis is? 2 days? 2 weeks or 2 days? we are not that quick. So the target for first episode psychosis is 2 weeks. If someone presents with psychosis and they are referred to the first episode psychosis, we have to see them within 2 weeks. That is the national target. Obviously, government sets targets for various conditions, and they want that to be met, and then obviously the target will keep reducing. So, as things develop. So, first episode of psychosis is given so much of importance within the UK healthcare system, even though the funding is limited, but, a lot of emphasis is given. And the reason for that is because there's something called as duration of untreated psychosis. So because when someone presents with psychosis, there will be some early warning signs. They don't present with hallucinations and delusions, from day one. Or at least they might be presenting, but they might not be telling. The family will notice some things, or friends will notice some things are some things are not right. And then what we know is that the longer the delay in treatment, the poorer outcome. So you have to catch all of them and treat them as soon as possible. So ideally, someone presenting with psychosis should be treated within 3 months. They should be on treatment within 3 months. So that affects the whole trajectory of their life, their prognosis, how, if they are not treated that quickly, what happens is that they will have more severe symptoms. When I've mentioned the negative symptoms and the positive, the negative are they're not looking after themselves, they're not interested in anything. The positive symptoms are the ones where you experience hallucinations, delusions, and the chance of remission is it becomes very poor if they are not treated early. So that is why, and then the long-term quality of life goes really, it is quite poor. And this is how the early intervention in psychosis services was started. It was initially, it was a UK study, called the Northwick Park study, which found that there was a link to the longer duration of untreated psychosis with poorer outcome. And then, the early intervention psychoservice was initially started in Australia and then UK. I think 1990s. I think it's since then the early intervention psychosis there. The treatment options. Like any condition, we have to treat them with medication, but the difference here is that people don't recognize they are unwell. Neither do they recognize, sometimes the family also would not recognize they're unwell. The family would want to believe, it might be just a passing phase. And then that delays the treatment. So as a psychiatrist or someone involved in the mental health profession, we have to be very empathetic towards them. We have to explain things to them in detail. I generally use a lot of, because people understand medical conditions, so I use medical conditions to explain psychiatric conditions. Say, for example, I compare that with diabetes or hypertension. See, I will tell them, see, these are chronic conditions. There's no cure. You need treatment. And the earlier you treat, the lesser chance of complications, side effects, and things like that. So a lot of reassurance, a lot of explanation. And the other thing is that, we have to be quite empathetic towards them, because imagine us having to go through these sort of phases and then, treatment being delayed or not having treatment. So the mainstay treatment obviously is antipsychotic medication. I'm not going to list all the antipsychotic medication. There are quite a lot of antipsychotic medications that can be prescribed, and the thing about antipsychotics is that the numbers needed to treat a psychosis patient is about 3 to 4. So that you treat a patient with with antipsychotics, you see them improving in most cases. And then there are also psychosocial interventions, which includes psychological therapy, where there is cognitive behavioral therapy for psychosis, and these sort of help in them understanding the illness. Coming back to the scenario that I mentioned previously, obviously we did exactly what I mentioned earlier. See, and this was a patient who presented with the first episode of psychosis, and we treated her. Within 3 weeks, all her psychotic symptoms disappeared, and she was back she was admitted to hospital and she was back at home and was able to resume her normal day-to-day activities. So treating them early is crucial. I think I've covered some of the things. What I want to point out is sometimes we think we can cure psychosis completely. It's not the case. There is we wouldn't be able to cure it. So the 25, 50, 25% that I've mentioned is that in 25, these are rough figures, 25% of the patients, with treatment, they will come into complete remission. A majority of them will be relapsing and remitting. That means they will become well, and then they'll become unwell again, they will become well. So relapsing and remitting goes, and then 25% of them will be considered as treatment resistant. But the key thing is early intervention. Some of the things that we monitor, are they taking their medications regularly? How are their symptoms being controlled? Do they have any side effects? One thing that I want to highlight is physical health monitoring is very crucial in a person with schizophrenia because their lifespan is 15 to 20 years shorter than most of us. So physical health monitoring is very important. And what are the barriers? The barriers to treatment is the same whether you are in the UK or in India. It presents in a different way. There is the issue of stigma is there. It's not just stigma from family, even from the medical fraternity also, there will be a level of stigma. That's, again, it's to do with our understanding or lack of understanding, which leads to a bit of stigma. But if they understand that this is a treatable condition, we can reduce stigma. Even in the UK, there is sort of disparity in healthcare provision for someone who's mentally unwell. Then there is the issue of side effects of medication. Antipsychotics do have side effects, and they do affect people continuing on treatment. So what can we do? I think one of the key things is that if we have a doubt, is this presentation something to do with psychosis? I think refer them early to a psychiatrist. Get them to be seen by a psychiatrist, and let them decide whether they have psychosis or not, and then start treatment if need be. One thing that the third point that I've mentioned there is increasing awareness among faith communities and leaders. So this is not a problem just in India. This is a problem all across the globe. So a lot of, whatever faith group you are in, they go to their leaders. When someone presents with a mental illness, they go to their leaders first. But whereas, if it's a physical illness, they don't go to a faith leader. So we have to work with faith leaders, and encourage them or teach them or make them understand or increase the awareness about mental illness among them, and that will definitely help. I'm going to stop here, and happy to take questions if there are.
Thank you, sir, for a very enlightening and breaking down a very complex topic into very simple language that could be understood by all of us. So, as sir discussed, it's very challenging to bring the patients to treatment because many often patients don't recognize or their families don't recognize that these are the symptoms that needs evaluation. So that's the major challenge that we have. So there'll be patients coming to all of us in all our OPDs with the subtle symptoms which might really warrant an evaluation. So I hope this session would help us to make the referral path a little bit more streamlined, and now the topic is open for discussion.
Hi, Suchitra, psychiatrist. So, how does it work in the UK for child cases in early intervention? I meant, Like if there's a child presenting with school refusal or child is mute, having selective mutism, for example, does the child present to the early intervention department, or how does that work?
Yeah. So so in the UK, psychiatric services are divided based on specialty. So the training system in the UK, for example, I am a general adult psychiatrist. So anyone who completes their training will be a specialist in one field. So there are the child psychiatry. Child psychiatry is a separate specialty. And within the mental health services, there will be the Department of Child Psychiatry, there will be the Department of Adult Psychiatry, there will be the Department of Old Age Psychiatry. So in younger kids, so child psychiatry, they will deal with patients up to the age of around 18 years. So if there are issues in school refusals and things like that, then schools could refer. The thing is that in the UK, the health service system is quite structured, where the parents might go to their general practitioner and then they will refer to the mental health services. So they will go and see them. So sometimes they might not attend outpatient clinics. So then the psychiatrist will go and see them at home. And that's the case even with adult psychiatry. So for example, there are some of my patients who might not turn up for appointments. So when I'm worried or concerned about them, then I will go along with one of our nurses or social workers to their home and see them. So that's how it's sort of child psychiatry or adult psychiatry, that's how it will work. So yeah. Does that answer your question?
Go to the child clinic, that's what I meant.
Yes. Yeah, I mean, if it's in the child, so early intervention services will be from the age of 16 to 65. But even within the child services, they will be able to manage that. Yeah, if they are under 16. So yeah.
Thank you, sir, for your talk. I'm a surgeon. You may not expect questions from a surgeon, but as many of us are in Believers Church Medical College working here now, so the term believer has many connotations. And personally, for you, how does your belief and your work mix, or does it mix or contradict itself?
Yeah. I mean, the thing is that, as Philip had already mentioned, see, I'm a Christian. I have a Christian faith. But that doesn't contradict with practice. So I consider myself as a Christian psychiatrist. The thing that I do, I mean, I was involved with a charitable organization in the UK which promotes or which educates about mental health issues within churches. So we have baby-friendly churches. Baby-friendly hospitals, isn't it? You've heard of the term baby-friendly hospitals. So this organization, they had coined the term mental health-friendly churches. That means, people in churches being aware of what mental illness is and directing them to seek help when needed. So I feel my faith in no way contradict with my medical practice. So, and I have friends, for example, friends of the Islamic faith, who they also do sessions in their mosque to educate them, because all religions, when it comes to mental illness, there is a bit of a thing where they will blame. I mean, they will attribute everything to demonic influence, or even in Islamic faith, they call it jinn. In Hinduism, they will be, I don't know exact term. So, but what I've seen so far is that these patients presenting with these sort of conditions, whether whatever faith they are in, you treat the condition. If the symptoms match a psychotic illness, you prescribe them antipsychotics, and they will improve. So I have a lot of patients who are committed Christians. I have a lot of patients who are of the Islamic committed Muslims. I am able to engage with them from the religious and medical sort of thing, and so I try to sort of bridge the gap, try to engage them, and I'll tell them, yes, even if it's a physical illness. I mean, we all know that miracles do happen and things like that, but when when there's a condition that needs treatment, you pray and also do the things that you need to do. That's how it is.
Yes, so since you have agreed regarding that aspect, so I will ask my doubt here. When the Bible says that Jesus cast away the evil spirit,
Yeah.
so how would you come to terms with that verse?
So it is not just evil spirits that Jesus Christ has casted away. The lame walked, the blind saw. So he performed miracles, not just people with mental illness. So this is where I don't discriminate between mental illness and physical illness, because Jesus Christ did miracles with people who are mentally unwell as well as physically unwell. And even this day and age, we see miracles happening in both domains. Thank you.
Morning, sir. Thank you so much for your talk. My name is Anne, and I'm a counselor. So I wanted an understanding about how we see gender identity issues. So this whole spectrum of LGBTQ and all of that. You talked about being a Christian psychiatrist as well.
Yeah.
So in the realm of all of that, that's something that is very prevalent among the youth of today. And I just wanted to understand how we could understand that better from a medical perspective.
I mean, this is an area where I have, what I usually tell people is that, I practice evidence-based medicine. So if any treatment that I give for an individual has to be based on some evidence. So if I see evidence on gender identity issues and things like that, then I will deal with them based on the evidence that's available. I will keep for example, when I'm working in a government sector like NHS, I have to keep my personal viewpoints to myself. But that doesn't mean that I will, any patient who comes in front of me, I will deal with them based on the available evidence. So if they need treatment for something, then I will treat them accordingly. I will not discriminate them based on their belief system. That includes anyone of any faith, anyone of any sort of gender identity sort of belief system and things like that. But obviously, the evidence for all this has to be there. What is driving all this? As of now, I haven't come across, or there's not enough stuff to make my own mind up on the nitty-gritties of this sort of issue. So.
Any more questions?
Thank you all so much for the questions that I've asked, engaging. I'm around if you want to ask me anything in private. Thank you.
Thank you, Dr. Joby. So thank you all for coming for the quest today. I hope it has triggered some thoughts in your mind. And he'll be around for a few minutes and before he leaves. And if any of you want to meet him, you're welcome. And next week, we'll probably not have a quest. Is that right, Abel? Because of the Onam week, I know many people are on leave. So we meet again 2 weeks from now. So thank you all once again. Have a good day.